So our next presenter is going to continue a little bit along with us on the theme of trauma treatment and emergency medicine settings. And I'd like to introduce Dr. Eric Vu, who's an emergency critical care physician for Vancouver Coastal and Provincial Health Services authorities. He's also an assistant professor in the Faculty of Medicine within the Departments of Emergency and Critical Care Medicine at UBC. He's actively involved in the British Columbia Emergency Health Services program, and he's going to talk to us today about the sort of paramedic out-of-hospital blood program that he's actively involved in. And he's got the greatest job because he's doing all kinds of really neat stuff of flying around the province, and it's like one of those guys you see on the medical TV shows that show up late at night on Channel 39. So anyway, this is what the real thing looks like. So Eric, please come join us. Toggle arrows.
Toggle, great, thank you. Well, thanks for having me, and thanks Dr. Hess for that work. I didn't realize you were going to be here. That takes away a lot of my slides. It's perfect. Before I begin, I'll mention I have no disclosures, and what I'm going to present has nothing to do with, or don't represent the opinions of Vancouver Coastal, PHSA, or the Faculty of Medicine, or BCEHS, because I usually get in trouble from somebody. What I'd like to present to you, however, was for sure and unequivocally a multidisciplinary team success for us in BC. I think it was Isaac Newton who commented on standing, seeing further, because he stood on the shoulders of giants. So I want to acknowledge the team that actually allowed us to do what we did over literally 5 to 6 years, and in particular, Ms. Shelley Feenstra and Kalani Polson, who were our leads. And others like Dr. Chipperfield, the brains behind this program that allowed us to take blood into the field in our helicopters, in our jets, what sounds kind of fun and on Channel 39, but in truth, most of us try to avoid the camera. That's about the most intelligent thing I have to say, so now I'm going to go into some pictures. And the reason I'm going to go into some pictures is actually to lay the foundation as to the operational framework in which we work. When I work in the emerge or in the critical care setting, it is vastly different from when I'm working either as a flight physician or as a flight paramedic. And I wanted to describe why we have extended this program into the field. So this is what our office looks like. And it can start anywhere from somewhere as close to the hospital, 5-10 minutes away, or in this situation, this was up between Whistler and Pemberton. A horrible accident that took several minutes, about 40 minutes, to cut the patient out of the car with what we call summer teeth, right? Some are in the patient's mouth, some are in the car, some are on the ground. But not to make light of the situation, when you consider the amount of trauma, this is a picture of the highway between Tofino and Victoria. These patients with severe trauma can be anywhere from a 14 to a 45-minute helicopter flight to our trauma center. So the question is, what happens in that time? And as alluded to previously, what about this so-called golden hour or golden hours, given that it's not really an hour anymore? So we go from these scenes, just a few people working on these individuals. This is actually not only a bad accident, but a public service announcement. So the guy in the big truck was on his cell phone, didn't see the small car and ran it over. So that's one public service announcement, not to have text and drive. The other one is actually to have your phone in your car, because the guy in the car is on his phone saying, "I'm still alive, help me." So there's my unit chief in this flight suit on the left, who was talking to the patient inside this car as there happened to be a crane across the street lifting the car off it. So they take off and they land here. This is our rooftop helipad at VGH. So BCEHS is a large ambulance service. We are, in theory, the largest in North America. And that's both a strength and a weakness. The strength for us is that we do cover provincially about just under 1 million square kilometers, but because we're a provincial program, it allows us access to cover all regional and air assets with a single system. This is an image just to give you an idea of how we're operating. And we have 4 main air bases in BC, which is vastly different. When you compare a map similar to this, when I was down at Vanderbilt, it looks more like a Dalmatian. There's an air base just as there are many Starbucks in the area, with competing air ambulances trying to get to the scene. Here in BC, we have 4 air ambulance bases. The main one's in Vancouver. And this picture here is our 24-hour nighttime coverage for the province of British Columbia for air ambulance. With that said, this is a quote I often use when I talk about transport medicine, is that in Canada in particular, with increased regionalization of our healthcare systems, we have to balance the access to that healthcare system for those individuals who live outside of urban areas. And we all pay the same taxes, so just because you live in a small community doesn't mean you should be access to less health. And so the onus has then been transferred to us with the provincial critical care transport program. We're actually doing less calls per year than we were 5 years ago, but the acuity of our calls have gone up several-fold because we're now having to move these patients to stroke centers, trauma centers, cath centers, burn centers, and there's a significant paradigm shift for us. So up front, as I was already alluded to, we know that, in particular why this is important, that uncontrolled hemorrhage is the leading cause of preventable death. What I find actually kind of interesting is that when you consider that injury, as alluded to, is the leading cause of death in age 44 and below and the leading cause of life years lost, it's a little bit frustrating and embarrassing when you consider the paucity of literature we have to help guide our resuscitative strategies compared to, for example, cardiac sciences. But what we've learned from some of these military lessons, in particular from Operation Enduring Freedom and Operation Iraqi Freedom with our coalition forces in the US and Canada, is that the damage control resuscitation or hemostatic resuscitation shouldn't start in the OR or in the ICU, but it should actually start at the point of entry. And my asterisk there refers to, from my perspective, the point of entry. The point of entry into the trauma systems of care where we can get access to advanced care to the patient at the site of the injury. So here's the bottom line up front. Our trauma resuscitation programs have shifted, but what we're doing now is recognizing that we need to be, if we're going to fill the tank, if someone is exsanguinating in front of us, the third bullet down, beyond what we were now doing in the field with the reintroduction of tourniquets and hemostatic resuscitation or damage control resuscitation, is the early and aggressive use of selective blood products. What used to be this paradigm, this 2 liters of normal saline up front, and Dr. Holcomb, him and I go to these annual meetings for special operations, and he was telling me that in his trauma center, if a trauma patient gets more than 3 liters of saline in a 24-hour period, it's actually almost an incident report. The trauma residents have to present themselves to him and explain why the patient got so much crystalloid. We don't carry normal saline in our emergency department anymore at VGH. In our critical care units for major hemorrhage, for trauma, sepsis resuscitation, we're using balanced crystalloids, so plasma light A, or if we don't have that, Ringer's lactate. So normal saline is no longer used from our perspective, pH 5. There's nothing normal about it, there's nothing physiologic about it. And so where we think what we're going now is that we've taken that previous paradigm and essentially flipped it on its head. We're now giving TXA at the point of entry, so our flight paramedics and our ground paramedics are now using TXA, and we've been doing that since about 2011. And we're now moving blood products far forward in the field. And right now, what I'm going to present to you is our Pac Cell program, but that was derived about 2009, before we had more data to suggest that we should be using balanced blood products. And so the second part of this is the introduction, hopefully, with our partners in transfusion medicine, is some kind of plasma product, or potentially in the future, depending on what our sciences show us, maybe some fibrinogen concentrate. So why shift care to the point of injury? Well, you've already heard why, from the acute coagulopathy of trauma shock, why that's important, right? Totally independent of all this normal saline that we're pumping into these individuals. The hyperfibrinolysis propagated by the hyperperfusion and the acidosis has to be stopped, and Pac Cells won't do that. And normal saline is just going to perpetuate that. From our perspective, what was very, very interesting is that when we did a review for our major burns trauma guidelines at VGH, we actually found that 90% of our patients spent more than 24 hours outside of our center of excellence at VGH. And the humbling point about that is that in the first 24 hours of burns resuscitation, the potential risk for over-resuscitation, abdominal compartment syndrome, dilutional coagulopathy, perpetuating burns, you name it, was huge. And in fact, we were doing as much harm with over-resuscitation as we were with under-resuscitation. And so we recognized that we can have these big guidelines at VGH, but where we needed them was in the field, up north, out east, in the Fraser Valley, where 90% of our patients were spending most of their time before they got to a trauma center. And the same is not necessarily untrue for trauma. So I'm going to skip over these slides because they've already been covered, but for me, the exciting part about some of the new research we're starting to see is evidence from the U.S. that has been, I think, derived in large part from military experience, looking at more balanced resuscitation. And so I'm going to skip over this because Dr. Hess has alluded to it, but basically the prompt study laid the foundation. This was an observational study looking at basically people planted in the emerge, looking at the proportion of balanced blood products that were given. And what they demonstrated was these basically the closer you got to 1-to-1, the better you did. And so again, in the first 6 hours, patients with ratios less than 1-to-2 were 3 to 4 times more likely to die than patients with ratios 1-to-1 or higher. This, of course, laid the foundation for the proper study. And, you know, Dr. Hess, you were humble in saying, you know, you may have had a conflict, but as someone who had nothing to do with the study, I can say that I think they were very modest in their conclusions. It surprises me that the FDA actually forced the control group to have a 1-to-1-to-2, because I would argue that's nowhere near the standard still. Although in academic centers we try to have balanced resuscitation, when you go into the community, or certainly in Canada, and I have the privilege to fly around the province, I can tell you we're nowhere near 1-to-1-to-2. So in fact, I think that the results presented and proper were understated because this so-called control arm, I think, currently exceeds standard community resuscitation. And arguably also at VGH, sometimes where I work, where at times we don't get the resources we need, or we don't execute as we perhaps should. So as was alluded to, the proper study didn't show significant differences in the 24 and the 28-hour endpoint or 30-day endpoint. But again, these were FDA stipulated endpoints that had no physiologic basis whatsoever. And then I come back to this slide, which is our trimetal distribution of death in trauma. And as you know, the majority of the injuries of deaths happen at the scene. We can't do anything about that. But look, if you look at the data again from prompt and proper, correct me if I'm wrong, but it was somewhere in the order of 2.6 to 2.3 hours where the second spike happened. And for me, the importance there is that that second spike, the number one cause of preventable death is hemorrhagic shock or exsanguination. And so again, if you look at the Kaplan-Meier curves or survival curves, and then I didn't actually have this slide that Dr. Hess presented, but at that 3-hour mark, there was a statistically significant mortality benefit in the use of balanced resuscitation. And why that's important for me is that, again, that's compared to, I think, a above standard control arm. And so that has, for me, validated what we're trying to do, or what we've been working on with our program here in BC. We know that earlier blood is better than late. Here's another study looking at thawed plasma in the emerge and showing that there's a 50% improvement in time to administration of plasma. Any takers on what this image is? World War II. So freeze-dried plasma, right? So we're hearing about it right now in the out east, or in the Afghan war and Iraq. However, this dates back to World War II. It's not new, but it's coming back. And we know that when we use balanced blood products, fewer are being used, as already alluded to. So again, what John has done down in U of T in Texas is that in his LifeLight program, they actually store 2 units of plasma, 2 units of Pac Cells. Vanderbilt, when I was last there, was just storing Pac Cells. Sydney, same thing. And for the time being, we have the same 2 to 4 units available to us as needed. But at U of T in Texas, they're using plasma and Pac Cells distributed as follows. With a 42-day shelf life, the Pac Cells are swapped out every 35 days, and the plasma is swapped out depending on whether it was thawed or what they define as liquid. And in the preliminary data that I think he's recently published, interestingly, look at the little happy face. How's that for animation? Improved acid-base status, decreased 6-hour and 24-hour transfusion requirements, and decreased 6-hour mortality. And again, some of the critics will suggest that a 6-hour mortality is not sufficient. But again, if you look at that trimetal distribution of death, and when you recognize when most people die of hemorrhagic shock, it's within the 2.6-hour mark. So I think that's an appropriate surrogate for assessing then all the other confounders, including multisystem organ failure, neurotrauma, and all the other confounders that we deal with in the critical care setting. They're a very successful 1.9% wastage unit. And so that process actually was published in parallel to when we started our program here in BC. What happened was after Trauma M&M's presentation at VGH, we recognized that in our trauma systems of care here in BC, that our patients were arriving cold, coagulopathic, and in part propagated by the fact that we were giving cold crystalloids that were unbalanced, pH of 5, that triangle of death that we always try to avoid. And so we approached Vancouver Coastal Health, Dr. Chipperfield and Shelley Feenstra, And we approached them and asked them, can we get blood for the field? Can we actually do this in BC in a more aggressive manner? Before, as an example, if we had someone exsanguinating in Tofino, sometimes, for example, we would fly to Paramedic, which is a 24-minute flight. We'd land their helicopter, which is not without risk, but we try to minimize our takeoff landings in urban settings. But we would wait 40 minutes with rotors turning for blood from Port Alberni to be made available to us, and we'd launch to Tofino with someone with a known hemoglobin of 60, active upper GI bleed, and then we'd kind of hope for our best for the 1-hour flight back to Victoria. And so our new process allows our critical care paramedics to have rapid access to Pac Cells, and we have usually 4 units available, and they're, in theory, available within 10 minutes from activation. The advantage of now aligning ourselves with the transfusion medicine individuals and the brains behind that program was that it allowed us to upregulate our training, improve our training to ensure compliance with Canadian Blood Services regulation, and of course to be accountable to our patients who we're trying to do well for. So this is the history of our project. We started in 2010 with a first conceptual meeting of the minds. We moved our original thought of using a blood bank near our air base to VGH just because of potential volume. In May, that's what I just alluded to. Then we actually looked into the actual packing box, and I'm not sure if anyone has any insight here, but we end up going with the Credo thermal packing box. Ordered it, bought it, validated it for its validity for use in BC. Developed our clinical guidelines to ensure that they were compliant with both CBS as well as Vancouver Coastal. A final stakeholder review, and then eventually 3 to 4 years later, we were ready to go live, and we had our first activation at the end of 2013. Many people raised eyebrows, and I can tell you that when we went to different stakeholder groups, there was concern about, quote, paramedics using or administrating blood. And so what I wanted to spend just a few minutes on is give you an idea as to why or what our paradigm looks like. Because in BC, we don't fly physician nurse in our LifeLight program, much like in the programs in the US. We have 2 critical care paramedics, but this is their background. They may start as an emergency responder. It's a very basic course. And then the majority of our paramedics, about 95% in BC, are primary care paramedic, or your so-called BLS or EMT for our US counterparts. After historically about 8 to 10 years of experience, they're then selected to become an advanced life support paramedic. And then after several years, usually 4 to 6 years as an advanced life support paramedic, they're eligible to apply to our critical care paramedic program. Our critical care paramedics, of our 4,000 paramedics, is about 60 paramedics, so less than 1.5% of our paramedic population are flight paramedics. They go through the UBC MMI medical school selection process. They actually go to BCIT and do the critical care nursing program. And then they do a supplemental 18 months, 3-semester, plus a 4th field validation. So it's essentially a 2-year program to go from an advanced life support paramedic, usually with 12 to 15 years experience, to a flight paramedic. As you can see here, we have faculty from all walks of medicine, including transfusion medicine. We currently use the same indications as we do at Vancouver Coastal. And as we've identified from our signals in critical care, again, the majority of our data and our research on blood transfusion is poor. It's mostly observational. So we do know that the more blood you give, the worse you do. We don't know if you do worse because you needed more blood or because you got more blood. But having said that, we are very, very strict on when we pull the trigger. And for every activation, we always consider where are they going, where are they responding to, does that facility have blood, what's the weather like, what's their delay to launch the aircraft, where it's fixed wing or rotor wing, so helicopter or plane. And all those factors are weighed in both with our dispatch, our flight paramedics, our transfusion medicine group, and then our medical oversight. And then we have multiple mechanisms to get that blood product to our aircraft. This is the Credo Box. Again, I have no shares or no conflict of interest with this company, but this is what it looks like enclosed. At the top, we have our water/coffee proof Starbucks or Tim Hortons, depending on your seniority, covering for our paperwork. And this little black bag on the side has the requisite citrate tubes to draw samples from our patients so we can actually do proper cross match at VGH before we give our blood products to avoid the mixed field, including our patient identifying band to allow tracking and accountability should there be a transfusion reaction down the road. As an example in terms of our paperwork, this is the flow sheet, and how it starts is that based on the dispatch criteria, our paramedics will make an assessment for interfacility transfer for now on whether blood may or may not be needed. They notify our blood bank, and then in a parallel process, within 10 minutes that blood is prepared, and either we do a rooftop pickup with a helicopter, we drive it out code 3 with our ambulance or one of our supervisors, or we will come pick it up ourselves if it's a long trip. Once the critical care paramedics get there, one of the things that we were quite strict about was the indication for transfusion and the accountability. And so our paramedics have 24-hour online medical oversight, and those physicians, in consultation with the treating physician in the community, as well as the critical care flight paramedics, will make an educated decision as to whether they should either pull the trigger and transfuse now, or have a threshold in flight. Because in flight we can do point-of-care testing, both non-invasive hemoglobin as well as arterial blood gas, actually do a proper arterial sample. Then we go through our standard protocols. We chose a specific monitor as 3 invasive lines so we can do baseline vital signs, temperature monitoring and whatnot for the detection of transfusion reactions. And thanks, Shelley, for these slides. I didn't know it was animated. I have no idea what that means or that means, but as you can tell, Shelley was the brains behind this. And some more pictures. So that's what our paperwork looks like with consent obtained, with either informed consent by the treating physician or by the patient if they're conscious. And this unit happens to have 4 units of Pac Cells, but that has changed. Our paramedics documented in according to CBS regulations and Vancouver Coastal standards. And so here are results so far. Since the end of 2013, we've done a total of 20 activations. As you can see, it's a lot less than we anticipated, mainly because of the logistics behind it. And what I wanted to draw your attention to is that of our total of 58 activations, there have been a total of 4 units wasted. And the reason that they were wasted, the asterisk refers to the fact that we were packing 4 units in the cooler, and as soon as we break that tab on the cooler, those 4 units either have to be used or tossed. And so what we've done now is that each cooler carries 2 units, and then if necessary we'll go with 2 coolers, and since that time we've had no wastage. So about 6%, but small numbers. So we think, modestly, I'm happy. I think it's pretty good. And to give you an idea where we're going, mission profile, Whistler, Hope, Williams Lake. This is not an exhaustive list, but gives you an idea where we're going with this program right now. And for those of you who aren't from British Columbia, we're essentially looking at anywhere from about 24 minutes flight all the way up to about 1.5 hours. And so this is an interesting VGH transfusion medicine newsletter where they actually recognize for some of our individuals who flew up to Williams Lake, and they got there with 2 multi-trauma patients, one with pelvic fractures. And I'll just draw your attention to this one right here in closing here. The CCP crew had to fly to Williams Lake, drive 6 hours, overnight in the clinic. The weather was down. And again, in a conceptual perspective, you think, well, we're in an advanced system, we've got an incredible trauma system of care, we have a lot of helicopters and planes, but the reality is at night we have 1 flight crew due to weather, safety, and funding. And these guys go anywhere in the province and are often stuck, snowed in, and spend the night with these individuals. And so what on paper looks like, well, why do we really need to take blood and put it in the field at what cost? You have these situations where people are literally bleeding to death in small communities where sometimes our planes have issues or we're grounded because of weather and we have to overnight with these individuals. And as our science evolves with the understanding of better resuscitation from hemorrhagic shock, we're now better suited to manage these individuals. And so what we're looking forward to now in our next phase is to have our current out-of-hospital resuscitation paradigm align itself with our understanding of our current evidence. And even if it's imperfect, we currently believe, I believe, that the balanced paradigm of 1-to-1-to-1 is the way to go. And so for that reason, what we're in the process of looking into is to getting our units to have 2 Pac Cells and some form of plasma preparation. What I also am interested to see, thanks to individuals like yourselves, is whether the signal for fibrinogen concentrate or any other concentrate comes down the pipes that would be amenable to use in the pre-hospital field. Well, that's it. Any questions?
Thank you. Really interesting talk, and on behalf of CBS, really glad you got your O-neg wastage rate down to 0. That's wonderful. sort of all joking aside, I'm quite interested in what the potential is for the application or perhaps reapplication of freeze-dried plasma in this setting. So on the Canadian Blood Services side of the house, we have been looking at working with the forces because they're interested in reintroducing something that is more in Canadian control than the American or French products that they currently have access to. Mm-hmm. And obviously the military application would be fairly small volume, and we're just sort of curious whether there's a civilian medicine application to that, so I'd be interested in your view.
100%. So at the Special Operations Medical Association Forum that historically has been in December, this year it's been moved from now on in May in Charlotte. We hear from all the U.S. and Canadian surgeons, and the Israeli Defense Force, their current standard is freeze-dried plasma up front. And then depending whether you have access to French or German FDP, then you're golden. To be honest with you, my experience with Health Canada and our maturation of process in Canada was such that we just didn't anticipate it ever be available to us in a reasonable time, and so we haven't asked. Our first question to CBS was, what kind of plasma products do we have available that will maximize time out of hospital to minimize our rotation from the blood bank and minimize wastage? But if there's a signal for freeze-dried plasma, if you look at what we're doing, 100%, I'm a believer that it should be plasma first. Most trauma patients, even if you bleed from 150 to 100, are they anemic? Yes. Do they need resuscitation? Yes, but do they have a critical deficit in oxygen carrying capacity? No. They're hypovolemic, they're coagulopathic, and they're hypothermic. And so what we use is the on-flow as a warmer. My toxin of choice would be freeze-dried plasma, followed by Pac Cells, and then once they get to a trauma center, then we can go towards platelets. If we have access to products that allow us to do this from a logistical perspective, it's easy. We have all the reconstitutional solutions, and from a licensure perspective across Canada, the signal to CBS is yes, critical care paramedics are licensed to reconstitute and to administer blood products. We were able, with the help of transfusion services here, get the provincial transfusion medical advisory group support to have actually pre-hospital implied consent, because we have 24/7 medical physician oversight. So I think up front, a one-to-one protocolized resuscitation is appropriate, and then once you move into the trauma systems of care, probably closer to the anesthesia critical care setting, then you move to a ROTEM and a TEG driven. And I don't think it should be originally one or the other. It depends on your phase, and to be frank, when it's just you and your partner on the side of the highway or in a small community, the simpler the better. And so if we can get freeze-dried plasma, that'd be fantastic.
So we have to the same Health Canada process that you were alluding to, so that part of it won't go quickly, but I think we're developing a commitment to try to bring that product to Canada.
That's great.
So.
That's great.
Half of all the seriously injured trauma patients in the United States go to trauma centers that are level 2 or below, where they don't have rapidly available blood products. And so having, certainly all across, eastern Washington, the small hospitals don't have plasma supplies on a regular basis. And so having freeze-dried products would make them available, to these urban or rural, life-saving and community service hospitals for delivering babies, for taking care of industrial and agricultural accidents. LifeLight Northwest is the helicopter service of the University of Washington. It brackets you because we serve both southern Alaska and Washington State, and so we're overflying you. And we put in place the very same Credo cooler. We use 2 units of red cells and 2 units of liquid A low titer B plasma in the box. We have activated about a dozen times. Our first one involved a 60-year-old woman who was climbing a tree in the Olympic National Park to gather moss for her research, fell out, broke her pelvis, was taken into Port Angeles and then met by the helicopter and flown in and given blood en route. She arrived with a pH of 7.1 and a hematocrit of 23, so we can only assume she would only have been worse if she hadn't gotten the blood en route.
I think one of the other signals based on what you're alluding to is from a logistic perspective for you guys to consider is that for people like myself who aren't as facile with blood components, if you look at the theoretical access, even in a level 1 trauma center like we are at VGH, we don't have plasma in our ED. Theoretically, we can get it quickly, and Shelley and I have discussed this at length, but the logistical and operational barriers to actually getting access, to thinking about it, pulling the trigger, knowing how much to call for. If you were to survey my colleagues in the ED, you'd get I would expect a pretty large range of answers. And so from my perspective, 90% of our efforts isn't into the physiology or the ratio. It's actually about logistics and operations. And sometimes it's taken for granted that your expertise in this room doesn't translate to an active trauma room. And we've always, every time I call a hematopathologist, it's quite helpful in transfusion medicine. But in this trauma resuscitation, we don't have that luxury, we don't have that time. And so one of the big signals from this, or one of the greatest experiences from this process was the logistics. How can we streamline it to get the right product to that point of entry into the trauma systems of care? And that's what the process of evolution that we hope to continue to learn on. Yeah.
Hi, I'm the hematologist on the combat trial going on in the U.S. right now, which we thaw 2 units of AB in the ambulance when they reach the scene. And you're randomized between salt water and AB right there.
Yeah.
And I designed that because no one's going to argue with thawed AB, which in a waterless water bath takes 2 minutes and 54 seconds to thaw. So we actually had to do that for the FDA. We're working on a waiver of consent, and we own our ambulance service. So we get field samples of coag factors, rapid TEG, proteomics, metabolomics, what have you, before any resuscitation occurs. We are halfway through right now. Some people might be sitting on our DSMB here. I'll be quiet. I think before you jump to freeze-dried, and the reason the U.S. stopped freeze-dried in glass, I believe, was Hep C.
Yeah.
And it is a U.S. process, but imagine going into combat carrying glass on your back. I'll just leave it there.
Yeah.
And getting shot at. Never been in combat, so wouldn't know, but it doesn't sound good to me. Yeah. So I just wanted to make the comments that we have an FDA IND for this, waiver of consent for this stuff. And I believe until some of, now it's only at phase 2B, and VCU dropped out, Pittsburgh is in still. So we may have to prolong our phase of the trial to get enough patients, but we have 36 ambulances.
Fantastic.
Going out doing this now. And unfortunately, I work out at the YMCA with some of the EMTs, and they're saying, can we get more AB? And that's all I know. But again, we're under the 28-day mortality with the FDA and everything else, just like the other studies. I would like to comment, I come from the group that does not believe in one size fits all. And our data wasn't shown, but that's fine. That happens a lot.
I concur.
We don't believe in that, and our randomized control trial looking at standard coagulation following of these patients versus TEG-guided resuscitation was accepted 8 weeks ago. It'll be in Annals of Surgery, and showed a 16% survival and less blood product usage compared to standard PT, PTT, fibrinogen. And being a pediatric hematologist, you can imagine the excrement I got for using a TEG.
Well, for every complex problem, there's a simple solution, and it's always wrong. Great, thanks.